Okay, so this is our MSK lecture that focuses on MR. A lot of people, depending on where you train, don't get a lot of MSK MRI exposure. Fellows tend to steal it all, so I'm going to make an attempt to cover everything that I think you need to know with regard to MSK MRI. It's a lot of sort of just Ant Mini stuff, but I am actually going to go through and try to explain some of the more confusing topics and spend probably the most amount of time on the shoulder. So let's start off on the ankle. So just we touched on this briefly before. I'm just going to review the anatomy really fast. So Achilles tendon here, little guy next door is the plantaris. Here's the fibula. So these are our peroneal tendons, longus and brevis, and then we've got our extensor tendons here. The big one is the anterior tibialis. That's the only one that matters. The other ones nobody cares about. And then we have our medial flexor tendons, Tom, Dick, and Harry. Remember that these two will end up crossing over. Harry will go to the big toe. Hallucis goes to the big toe. Digitorum will go to the remaining toes. And posterior tibialis it sort of wraps out around and will be a major player in the arch. So here's normal, just like sort of like we did with the T-bone. Like look and see what's different here, and you probably have noticed that peroneus brevis is sort of stretched and deformed, almost looks like a boomerang. So this is a split brevis. It's common. It's so-called boomerang sign, where, and I think that that's the most likely way that it'll be shown. You know, you can show partial tearing a whole bunch of different ways, but because it has a named sign, it's most likely to be shown that way. History is typically chronic ankle pain. It's almost certainly going to be asked as a what is it question. There is a strong association with lateral ligamentous injury, given that it is a lateral tendon. So a mechanism that would tear it would probably tear lateral ligaments as well. So let's just sort of like, why does this happen? Here is a cartoon of the tibia and fibula, and if we took a cut right here at this level right there, and then we looked at an axial, this is what we would have. And there's this, the cutout here is this retromalleolar groove, and that's a groove that these peroneal tendons sit in. These guys, longus and brevis. But not everybody has a groove that looks like that. Some people have a groove that is flat, which isn't a groove at all, I guess. And then you've got other people that actually have an outward convexity. And you can imagine that people that have an outward convexity, if they were to invert their ankle, that would put a lot more stress on those tendons than if they had sort of that concave hole thing. Other things that can do it would be if you had a low-lying muscle belly, peroneus brevis, the muscle body too low, it's like Mass Effect down there. Or if you have a accessory muscle such as a peroneus cordis, which is probably the most common one in the ankle, that also can crowd that space there and make those tendons more susceptible to being injured. So let's look at another foot case. This is a good way to show you an acute flat foot. First by showing you a normal arch, and then by showing you within a very short period of time that the foot has gone flat. Or they could just tell you the patient now has a new flat foot, acute flat foot. So there's chronic flat feet, and then there's acute flat feet, and those are totally different situations. Acute flat foot is going to be an acute injury to the arch stabilizers, and there's just really, I'm going to go through them, but there's one in particular that you should think of immediately when you see that. So here we go. This is backwards than what we've been looking at. Notice the fibula's over here, just to orient you. So peroneus, longus, and brevis here, And then here are our medial tendons, Tom, Dick, and Harry. I'll show you the normal one there. So let's look at the normal one again. Achilles, plantaris, peroneus longus, brevis, hallucis, digitorum, posterior tibial. Okay? Tom, Dick, Harry. You probably have noticed now that Tom is out to lunch. So Tom is like gone, right? We don't see him. So this is a tear of the posterior tibial tendon, PTT. It's the most commonly torn tendon of the medial ankle. It's usually a big fat diabetic on chronic steroids. So sort of putting all the risk factors together. You can have what's called an accessory navicularis. It's just one of those of the many accessory ossicles you can have. That one in particular is associated with higher rate of injury to the posterior tibial tendon. So it's a major arch stabilizer, and if you take it down, it can lead to an acute flat foot. Usually have something like this that occurs. So medial ankle sequence. Now, when I say sequence, what do I mean? This is what I mean. I'll give you an example of another sequence. First, you get the money, then you get the power, then you get the women. That would be an example of another sequence. So just like that, we are going to look at the medial ankle sequence. So this is normal. And what I'm trying to show here, this one's normal. What I'm trying to show here is the spring ligament. And notice that it sort of looks like a hammock, sort of holding the talus up. So if you tear that thing here, your talus basically can slide off. I've actually seen a case where it slid totally off and contused on the sidewalk. So, in addition to the posterior tibial tendon, the spring ligament is another sort of arch stabilizer that's holding things together. So if you lose your posterior tibial tendon, the next one to go is often the spring ligament. And then when you lose your spring ligament, then you end up with a flat foot. So, showing you this here, this is a T1. I know it because the marrow is fatty. And so sort of white marrow, fatty marrow, and then you can also see fat here. So this is a T1. Show you normal. This is what normal is supposed to look like. Just notice the difference. Fat here in the sinus tarsi. Fat here is obliterated. So this is so-called sinus tarsi syndrome. That occurs from sort of abnormal mechanics. And why does this matter? Well, the nerves in the sinus tarsi are important for proprioception of the hind foot. And there's also some talocalcaneal ligaments that live in the sinus that help with stability. Basically, the end result is a painful, wobbly foot. And that painful, wobbly foot leads to this. So I got an arrow here pointing the fluid right at the Achilles, or right at the bottom of the heel where the plantar fascia, one of the bands of the plantar fascia runs, showing it with ultrasound with calipers on it. How do you know it's too thick? Because there are calipers on it. So for the purpose of multiple choice, people are putting calipers on stuff. It's probably either too big or too small. This looks too thick, so I'm saying it's too thick. If you really want to know, people will say greater than 4 millimeters. I just remember there's calipers on it. So this is the sequence. Posterior tibial gone. Spring ligament gone. Flat foot. Sinus tarsi. Now you've got a wobbly foot, and you begin to have an abnormal gait and heel strike on your painful flat foot. And then you get plantar fasciitis. So this has been described in literature as a known sequence that occurs. So if you see one thing, you're supposed to look for the next, and if you see the next, then you're supposed to look for the next one. And all sort of that ankle pathology sort of goes together like that. All right. Moving on, out of the ankle now, moving into the knee. Right there, that thing. So we're on the lateral side here. That is a so-called Sagan fracture, right? And when you see that, you're supposed to think about this. So edema in the bone here, edema in the bone here. This is a so-called kissing contusion sign, strongly associated with tear of the ACL. So PCL here, ACL is supposed to run like this. Don't see fibers. You want to see fibers. Instead, you just see hamburgers. So that's a torn ACL. So anytime you see a torn ACL, the next place you're supposed to look is the posterior lateral corner. Now, why? Who cares? People who might write multiple choice care, which is why I mention it. The other reason that it matters is that, so you get a torn ACL, what happens? You're going to get surgery, right? You're going to get a graft placed there. But if you have an unstable knee, it's going to wobble and not, it's going to put abnormal stress on that graft, and the graft will fail. And one of the most common causes for graft failure is an undiagnosed posterior lateral corner injury. Now, the posterior lateral corner is one of the most complex parts of anatomy in probably the entire body. There's like 37 structures or something in the posterior lateral corner. There's a lot. Too many to remember and too many to be tested on. If you were going to show posterior lateral corner injury on multiple choice, the way that I would show it and the way that I look for it in the real world is I look for edema in the fibular head. So, and then I would say something like correlate for instability in the posterior lateral corner. Boom, next case. But right there, that would be the way to show it. So in the setting of a torn ACL, edema in the fibular head, think posterior lateral corner. And it only matters basically because if you've got instability there, it's going to fuck your graft up and you're going to have early failure. All right, next case, still in the knee. And what we're seeing here is a weird-looking too many triangles, right? It's supposed to look like a bow tie or two triangles, depending on what cut you're at. And we've got a triangle with another triangle in front of it. This is the so-called flipped meniscus sign, where you have a displaced tear of the meniscus, where you've avulsed a posterior horn and flipped it into the anterior compartment. You can sort of use your imagination there. This is another very common thing, shows up in case books and case conference and stuff all the time. We've got one PCL here, and then we've got a second PCL there, so we've got two PCLs. That's one too many PCLs. This is a so-called double PCL sign that is seen in the setting of a bucket handle meniscal tear. Now, when you see this, you know something else, which is that your ACL is intact. For this to occur, it requires an intact ACL to have the background anatomy for that to flip like that and hold like that. All right, next case. So, coronal knee gamesmanship. If I show you a coronal knee and there's not a bunch of edema in the bone like a sunk, that this is the thing you should be looking at right here. So this is a discoid meniscus. Notice it's going all the way across. Shouldn't do that. So normally meniscus are horseshoe shaped or C-shaped. This one is shaped like a disc. It's too big, too much. There's too much. It's always lateral for the purpose of multiple choice. Yes, you can have them medially. For the purpose of multiple choice, it's always lateral. And why do you care? It's because they are high risk to tear. You will have meniscal tears in kids. Um, the other thing to know is that there are actually several different subtypes of discoid meniscus, but there is a named one which makes it more likely to show up in multiple choice, and that's the Riskberg variant, and it's allegedly the most severe type. This is another way to show it. This is the too many bow ties. It's sort of a flawed way to think about the meniscus, in my opinion, because if you say, well, there's supposed to be two bow ties, there's supposed to be three bow ties, well, in who? In my knee? I don't know. In Grandma's knee? And what about Shaquille O'Neal? What about his knee? How many bow ties does he get? I bet you he has more than three. He probably has 5 bow ties, and it's probably normal. You have a giant guy, more cuts that go through there as opposed to like some 70-pound little person. Then maybe they only get 1 bow tie. I just sort of like it's a good way to learn it for somebody that has no experience and doesn't know what normal looks like. If you get in the habit of counting them, that's probably a good way to look at it. Once you sort of have looked at a few, then you can just tell there's too many, or you can look at the coronal and notice that it's stretching all the way into the notch. But for the purpose of multiple choice, I think it's much harder to show you a scrolling thing where there's multiple bow ties in sagittal plane. That instead, I think it's more likely to be shown in the coronal. But just be aware, there's this idea of too many bow ties or not enough bow ties and that kind of stuff for people that look at the meniscus in a sagittal plane. All right, next case here. I'll have to zoom in here. That thing. So it looks like fat, right? We got fat here. There's fat in the bone, and then there's this looks frond-like, maybe like a bush or something. And that is the lipoma arborescens. It's not common, but it is an ant mini, so that kind of stuff tends to show up on test. Sort of looks like a shrub, and it's basically a synovium full of fat that is from chronic inflammation. All right, next case in the knee. This is another ant mini. I'm going to ask you this real fast. Orient yourself. Is this side here lateral or medial? And how do you know? It's lateral, right? Because the way that I remember is that the lateral side points that way. So the pointy side is lateral. So notice that there is a contusion here and a contusion here. So like this thing slipped off here, banged into that, and then got pulled back across. In the meantime, because it was going this way too far, all this got torn. So that's all hamburger. So this is a patellar dislocation. Pretty much always occurs lateral. And then when you do it, you tear this thing here, which is your MPFL, medial patellofemoral ligament. People who get them tend to have trochlear dysplasia. What's trochlear dysplasia? This is trochlear dysplasia, where your trochlea is flat instead of looking like this, where it's got like a hole. There's a classification system for those. You do not need to memorize that. All right, next case, another knee case. And what this is trying to show is this right here, maybe some people would say that looks like a drumstick. And this right here, maybe some people would say looks like a celery stick. This is mucoid degeneration of the ACL. It's a common cause of increased signal within the ACL. It can mimic an ACL tear. Like if you were looking at this right here, but of course on other sequences you can see that those fibers are intact. It's another ant mini. It's worth knowing. All right, so that's it for the knee. We're going to move into the elbow now. elbow people are often even less common or familiar with. So just to orient you here, it's the radius, right? That makes that the ulna. Put your hand in anatomic position. That's so palm facing forward with your thumb out, and you will figure out that this is the lateral side, right? So your radius is lateral in anatomic position. You know, you walk around normally and your thumbs sort of point in. So don't call that medial. Remember, rotate your hand out for anatomic position. So this is a lateral. So that's where the high signal is. Look for the high signal when you don't know what you're looking at. And that's the lateral epicondyle. So this is tennis elbow. It's basically a partial tear of this common extensor mass. Flexor one's on the other side, or on the medial side. And I think they call that a golfer's elbow. So that's one thing that could be shown. This is probably the most likely thing to be shown, because this is, I remember as a resident that, and they've ever showed an elbow case in case conference. This was the only thing that this is the only thing that I knew, and then it was the only thing that, and I would always get the case right because this was the only elbow case there was. So that right there is supposed to look like a T. See that? So this is the ulna. We're looking at the ulna here, by the way. All right. See, look how far. Here's the olecranon fossa. Right. So we're in the ulna to cut through, and we're seeing this signal here. They'll often do gadolinium arthrograms to look for this. This is a partial UCL tear. There are 3 bands to the UCL. The anterior band is the only one that really matters. It's the, quote, important one. Who do you see this in? You see it in throwers because they do a valgus overload where they bring their thumb. So what does valgus overload look like? If you can imagine taking your thumb and trying to reach all the way behind you with it, it's sort of a valgus overload, but like stretching out palm up, reaching backwards with your thumb. That's what throwers do when they like wind up. Now, who cares if you, assuming you're not a professional athlete, had a partial tear of your UCL? They would do nothing for it. But in throwers, they may do something called a Dami-Johns procedure, where they take the palmaris longus, one of those tendons in your wrist that you don't need. So if you look down at your hand and you flex with a flexion motion, you see either 1 or 2 tendons in your wrist. If you see 2, one of them is the palmaris longus. You don't need that. It's left over from being a monkey or something. They will take that thing out of there, and they will reinforce your ulnar collateral ligament, which actually gives you gives you superhuman range of motion, so you can really valgus overload. Then you can actually throw faster with that. All right, I'm all slightly off topic here, but what you need to know is ulnar collateral ligament, T sign, valgus overload, anterior band of the UCL, seen in throwers. The thing with the arrow on it right there has a fancy name, therefore it's subjective to multiple choice testing. It's called the sublime tubercle, and that's where the anterior band of the UCL attaches. And when it tears partially, you get a T sign, seen in throwers, valgus overload. All right, here's another. Now we are in an axial plane here, and we're going to do an elbow case, and we're going to scroll down, scroll down, scroll down. Okay. Scrolling down. Oh, we're scrolling up, actually. Well, down, depending on your perspective. So this is the thing I want to point out to you, is this right here. Okay, watch that black thing. All right. So that is the biceps tendon. All right. Biceps comes down on the radius. All right. So that is the bicipital radial bursa. That's that fluid thing. All right. Biceps tendon attaching right here. Okay. Following it back. Following it down. bursa there. Bicipital radial bursa. So it's where the biceps attaches on the radius. There's a bursa. Looks like that. That's all you need to know about it. All right, done with the elbow, mercifully. Now we're going to move into the hip. We've got a stir showing you high signal here. T1, I'll tell you that there's no collapse or anything like that here. I'll tell you that this person has had no trauma. I'll tell you that this person may be pregnant or was pregnant or something like that. Now, this is transient osteopenia of the hip. It was classically described in the third trimester pregnant person. It's painful, so painful hip in a pregnant person. You get an MRI, you see high stir signal. It's actually more common in men, but for the purpose of multiple choice, I would expect that it would be the pregnant third trimester woman with hip pain because it's how it was classically described. Sometimes it migrates, and they will call that regional migratory osteoporosis. That's probably less likely to get asked. This would be more likely to get asked because it's one of the causes of edema in the hip. Here's another cause, and this is more classic, right? We've got our serpiginous line, and then this is a so-called double line sign. We've got a dark line with a bright line right underneath of it. That's like 100% sensitive or specific or something for this AVN. So who gets AVN? Give me like 4 or 5 causes. So steroids, trauma, sickle cell's a big one, Gaucher's, alcoholic. If I was going to remember one, I would remember steroids. If I was going to remember 2, I would remember steroids plus sickle cell. All right, next case here. May or may not be able to see it. There's a fracture here. Okay, just looks like it sort of goes from here to here. I will tell you that if you see this, what you're supposed to do, next step, this would be a good next step question, is to get an MRI. Well, why would you do that? Because the extent of these fractures is often underestimated. This is a so-called tip of the iceberg fracture. There's several different ones, but this is probably the most classic one, and that the fracture is actually way bigger than they thought it was. So, whereas I don't know what the management is for a fracture that's isolated to the greater trochanter, but let's just say that it's conservative. This might not be treated conservative now that it's all the way through. So changes management. So it's a good next step question. If you see a little fracture in the greater trochanter, you need to get an MR to look for extended disease. Okay, so we're going to move into the shoulder. This is going to be the last joint that we do. First case is here. This is probably the more classic way to show it, but I'm showing it 2 different ways here, and I will tell you that there is a thickened middle glenohumeral ligament, and there is absence of the anterior superior labrum. Should be like a triangle looking thing here, and there's not. And then we got this big fat thing here. This is a so-called Buford complex. So let's take a look at the labrum here. This is the way that I like to look at. I like to draw crosshairs on it. People will describe these quadrants like this. And then in each quadrant, there's different pathology. So when you've got a normal variant, which is, so this is the middle glenohumeral ligament. This is the biceps tendon here. These are your inferior glenohumeral ligaments. So when the middle one, instead of attaching here, attaches all the way up there, and you are missing a part of the labrum, that anterior superior labrum, that's what's called a Buford complex. Who cares? It matters only that you don't call it abnormal, so that they try to fix this, quote unquote. The anterior superior labrum has the most variable blood supply, and as a result is A, the most prone for injury, and B, the most prone to sort of anatomical variation. So looking at this thing again, Let's talk about the anterior and superior labrum again. You've got, so the Buford complex is one of the variants that you can have. Another one is a sublabral recess, sort of looks like that. Notice that this thing does not go below the equator, okay? You can also have slap tears there. I'll sort of show you the difference. You can have a sublabral foramen that extends down again, doesn't go past the equator. Buford complex. In the anterior inferior labrum, you can have Bankart injuries, and there's a whole spectrum of that. And then you can have posterior labral tears as well. So this is sort of the way to look at it. Sublabral recess, sublabral foramen, Buford complex, slap tears, Bankarts in the anterior inferior, and then a whole bunch of posterior stuff that I wouldn't worry about. Of course, we can have, slap tears also. So you can start out talking about those. The way that I think about slap tears is that you basically have degenerative tearing, and this is from being a normal person working out over the course of your life. You just crush your labrum, and it changes from a black color to a gray color as it gets chewed up. Or you can have a slap tear, and this is more of like a knife-like injury that it is seen in like overhead throwers or overhead movement athletes like swimmers. Now, technically by the book, a slap tear is a superior labral tear that extends from anterior to posterior, and you can have those when you're 70 years old if you have a superior labral tear. But, and this is just my opinion on this, I look at a slap tear as a tear in the labrum on a background normal labrum, whereas a degenerative labrum, the whole thing is just crushed up. So this is what I mean by degenerative tearing, right here. Notice that the labrum is supposed to be completely black, It's all gray, looks like a rat or some kind of a creature's been chewing on it. The whole thing is like this, sort of one of those canned circumferential degenerative change in the labrum, or degenerative tearing in the labrum. We're in another view here, we're in the axial plane, and again, it's supposed to be completely black, and it's just very frayed looking. I don't think that that's how it will be asked. I think if it's more likely to be asked, it'll be more likely to be asked like that as a slap tear. So who gets slap tears? One person who gets them are overhead throwers. Another kind of person who would get them would be this person. Someone who falls, lands on sort of an outstretched hand. Why does that happen? Because your long head of your biceps attaches at the 12 o'clock position of the labrum, and it gets torqued, or is in a repetitive overhead activity that's constantly getting torqued and twisted like that. And as that happens, it sort of pulls off that superior portion of the labrum, is the most prone to being injured, like that. So there's like 100 different classifications of slap tears, but the most original one is a 1 through 4, and it's probably the one that's, if anything gets asked about it, that's the most likely way it'll be asked. So type 1 right at the top, type 2 with either extension anterior, type 2A, or extension posterior, type 2B. Type 3 is a bucket handle, and type 4 has extension into the biceps labral anchor. Now the only one that really matters is type 4, because if there's extension into the biceps labral anchor, they will do a biceps tenodesis where they cut the biceps tendon off. From an orthopedic surgeon's perspective, failed slap or any kind of shoulder surgery, the outcome is like persistent pain. Like if the patient says it still hurts, then the surgery's failed, right? Because as a patient, the only thing you care is like, make it stop hurting. So if it still hurts, even if it's like looks better on imaging, it's still failed outcome. So if they've got persistent pain because they've got biceps tendinopathy or they've got an injury to the biceps tendon, they can fix that by doing a tenodesis, and they will do that if you call it type 4 slab. So here's a type 2. This is the most common. And remember I said these are the ones that extend anterior and or posterior. So as we go through, normally you see a little bit of signal sort of can wrap around in this direction here, but if it's going forward like that, that's abnormal. And also it has sort of a jagged look. So something like that, right, like that. See how it's going forward? That's your slap tear, as opposed to a sublabral recess, which follows the bone and the cartilage sort of backwards like that, smooth, real smooth. They're located similar locations. That this can be more anterior and posterior, like I said, with a type 2. The big ways that I tell the difference is that it's going forward instead of backwards, and it has a jagged edge as opposed to being totally smooth. I will also tell you that if they're showing it to you, it's probably a slap tear. Okay, type 3 is a bucket handle. I feel like that's harder to actually be able to say for sure that that's what's going on. If I was going to show you a bucket handle, I would show it to you so that it looked like this. See that? You buy that? Biceps tendon is spared. If the biceps tendon was involved, it would be a type 4. There's your bucket handle. All right, here's type 4. This is the one I think matters the most right there. So remember the long head of the biceps attaches at the 12 o'clock position. Do you remember where the short head attaches? Coracoid process, right? So long head of the biceps attaches at the 12 o'clock position, and if that tear extends into it, let's see it here, right there, look at that. I'll show it to you. So we're looking right here. See that signal right there? See it now? Right here. It's a good way to show that. Boom. So tearing, extending into the biceps tendon, type 4 slab. That one gets a tenodesis. So there are some mimics. So as the biceps tendon comes across, it sort of lays down flat, flops down flat at that 12 o'clock position, makes a little cleft there. Some people might want to try to call that a type 4 slap. Don't do that. That's normal. That's what that looks like as that attaches. All right, now let's do the Bankarts. This is probably the highest yield. So as you get in, anterior dislocations are more common in the shoulder. Posterior dislocations are more common in the hip. The way I remember that is, think about the hip as the dashboard injury where you put on the brakes or whatever in the car wrecks and it blows your femur through the back of your pelvis, and that's the posterior. And then I just remember that the shoulder is opposite. So anterior dislocations in the shoulder are way more common. You can get posterior dislocations in people that have been electrocuted or had a seizure, or they've got weird stuff like they've got Ehlers-Danlos or something where they're real lax and they can just flop around all over the place. But as you move anterior, you end up with two different fracture patterns. One is the Hill Sachs, and that's on the humerus, and the other one is the Bankart injury, which is on the glenoid, that thing. And there's a big spectrum of alphabet soup that occurs. A true Bankart is actually an osseous injury. Here, that's the way at least that I think about it. And a true Bankart tears the periosteum, this thing, the blue thing. Now, reverse Bankart would just be on the opposite side, so it'd be like a posterior dislocation. So instead of being anterior, inferior, it's posterior, inferior. And then we've got this sort of spectrum that we'll go through here in a second. So normal versus a Bankart, that periosteum being torn off is going to make it a true Bankart all the way through. And there's a fracture of the bone. So what's that look like? Going down, eyes on. So here's the coracoid process, right? So that's how we know we're anterior. That thing is anterior. What tendon is that? Probably subscapularis, right? Because that's the one that's anterior. Moving across. Biceps tendon. Alright, so pay attention to this right here. So we're now anterior, inferior. That part's torn. Okay. Boom. Probably a little easier to show in this plane as we come through. See that? Anterior, inferior. This thing's sort of supposed to look like a pear right here. We've got that broken off. Boom. Alright, so there's a thing called perthes. Notice the periosteum is intact, but what's happened is the labrum has been torn and sort of it's ripped off, and it's still stuck to the periosteum there. So it's the anterior labrum is lifted from the edge of the glenoid, and it's displaced. What does that look like? Looks like that. That's the picture right there. That's the one right there. So, see this cartoon here, right here? Alright, as opposed to this, which is the alpsa, which is the scarred back one. And the way that I remember that is, I think about this as the S for scarred. Perthes doesn't have that. Well, I guess it does have an S at the end, but I remember this as sort of like perthes plus scar. Periosteum still intact, but instead it's like it's ripped off and pushed back and sort of smashed and scarred there. Alright, so what does that look like? Anterior labrum, periosteal sleeve avulsion. That's what that actually stands for. Alright, so we're going back. Look at that. Seen it? Okay. We're looking over here. So ripped off and sort of mashed and scarred back. Another plane. That one's less helpful. Okay, now this is on a spectrum, this one's the most mild. This is just a cartilage injury. These lesions are not associated with instability. That's a key take-home point for the GLAD lesions. Aren't you glad it's just a GLAD? It's the most mild, and it's just this cartilage has been scraped off right here, okay? Articular disruption. It's just the cartilage, see? This is the cartilage. We've scraped that cartilage off right here. So it looks something like this. This is cartilage intact, and then it's missing right through there. Cartilage, and then missing right here. Like a piece has been bitten off. See that? It's probably easier to see in this plane. Cartilage is gone. Okay, so here's a spectrum. This is what you have to know. Notice the periosteum's intact in all of them. If it wasn't intact, that would be a true Bankart. The ALPSA has the Perthes plus scar, PS. Like this, like scarred back. Perthes is just pushed off and sort of stuck on the side. The one that's scarred back is the ALPSA. GLAD is just, aren't you glad it's just a GLAD? It's just the cartilage injury. All right, so one more thing here. This is one of our inferior glenohumeral ligaments. What happens if we tear that? So that's a Hagel, an avulsion of the glenohumeral ligament at the humerus. So what does that look like? Looks like this. So right here, it's torn off. See that? Oh yeah. Right here. See that? That's what a Hagel is. Same deal here. See it? Go back. All this. Okay, see it now. All that. Okay, rapid review time. This one, anterior, inferior. It's the bone is broken here. That's a Bankart, osseous Bankart. This one here, it's lifted off, but it's not scarred back. That's the Perthes, right? Here it's scarred back. All right, that's our ALPSA. And then this one here, just the cartilage is broken off. That's our GLAD. Okay, that's it. That's it for MRI for neuro MR. The next lecture series is a neuro lecture series.